Good afternoon, all. iTech India welcomes all the participants for today's distance learning seminar series. Today's topic is Introduction to Opportunistic Infection and Central Nervous System. Today's speaker is Dr. Anwar Parvez. He is at Associate Professor at Department of Global Health and University of Washington. We welcome you, sir, for today's session and request you to start the session.
Thank you, Kiran, and good afternoon, everyone. I'm happy to be here today, and I hope I'm audible and my screen is visible to you all.
Yes, sir, you're audible.
Okay, so yeah. So as Kiran mentioned, so we'll talk about opportunistic infection and especially focus on the central nervous system after the initial part. You might have seen and I'm sure that you have listened to so many other sessions on the recent revised ART guidelines, which were released in 2021. And before that, the revision of OI guidelines, or in fact, the first time when NACO released opportunistic infection guidelines, that was back in 2007. And this revision has been done after a long time. So in this guideline, you will see many updated aspects of OI diagnosis and management. Kiran, I'm trying to get rid of this. There is something on my screen which I'm not able to get rid of. I don't know.
Sorry, sir.
My screen has this zoom. One second.
Please click on the enable editing and then first.
Enable editing?
Yes.
Where is it?
Sir, also your video is not showing.
Oh, 1 second. I'll share again. Okay, sorry for the interruption.
Yes.
Can you see it now?
Yes, yes.
Okay. So in this session, we'll start with the opportunistic infection first, and then we'll focus on CNS opportunistic infection. Although the list is very long, and it's almost impossible to cover everything in 1 hour of this RDLS. But what I'll try to do is I'll try to remind a few things to those who already have gone through such sessions before, and I'm sure most of you might have attended similar sessions in past. And especially those of you who have worked in the ART center for a long time and worked in hospitals also, you might have managed patients with CNS opportunistic infections. Thanks to ART, these days we don't see serious central nervous system opportunistic infection, or other than TB, I guess, other OIs are showing declining trend. And most of the CNS-related opportunistic infections are managed in the hospitals and not in the ART center. So the main purpose of having this session is, I guess, first of all, to have that index of suspicion whenever a patient comes to you at the ART center to know what to expect from those patients, especially if the CD4 is less than 200. And the second thing is, if the patient has been started on treatment in some other place, and because the treatment continues for quite some time, it is also the responsibility of the ART centers to look at the other treatments which patients are on other than ART, and talk about its adherence and completion and follow-up and all those things, which is very critical for patients' progress. And that is why this session has been added in this series. Otherwise, many of the ART medical officers, they do not actually manage the patients in ART. In fact, none of them. But in the hospitals, obviously, these patients keep coming if the CD4 is less than 200. So let's start with opportunistic infections. It's any disease caused by any microbial agent if the person's immunity has been compromised, mainly because of HIV. And that's what we call AIDS, acquired immunodeficiency syndrome. When we see CD4 less than 200 and there is occurrence of life-threatening opportunistic infections, malignancies, and other diseases, which makes patients really ill. So these are major cause of morbidity and mortality in the people living with HIV, not the HIV itself, most of the times. So that's why it is important to identify them on time and treat them. But again, thanks to ART, since the ART is being started irrespective of CD4 count. I remember those days in 2006-07, I worked in Chennai for 1 year as a fellow at GSTM Tambaram. That was the time when there was only one ART center, or I guess there were like few ART centers were starting, but in 2004, that was the only one ART center in South India, other than JJ Hospital in Mumbai. So there was a lot of influx from all parts of the country, especially from southern part of the country. And that was the time when we used to see all these kinds of OIs and used to manage them. And we used to see patients dying of many of these OIs. But with time and guidelines kept changing, we started better monitoring of patients with CD4 and viral load, and ART is being started very early. So in these days, that's why you won't see many of the OIs in the beginning. But the again issue is, if the ART is failing and CD4 further falls below 200, still there is a risk of all these OIs again. And that's why it is important to know when to suspect, when to diagnose, or how to diagnose, when to start the prophylaxis, when to start, and so on, and when to refer the patients to the higher centers and all that. So if ART is started within first 12 months of ART, risk of OI reduces a lot, except TB, which can happen at any CD4 count, and that risk is persistent throughout. Of course, the presentation of the TB varies, but still there is a risk of tuberculosis at all levels of CD4. So in summary, the incidence of OI depends on level of immune suppression occurring at CD4 cell count of less than 200, and how prevalent is the infection within the environment where the patient is situated. So that endemic prevalence of causative agent, that also decides the incidence. Because in India, TB is more prevalent, that is why we are seeing more common OI as tuberculosis as more common OI in India. Likewise, there are some geographies in India itself, like Penicillium marnifi is more common in Northeast, especially Manipur, but not other parts of the country. It is because it is endemic in that particular region. So this is about the risk of infection. So risk of opportunistic infections, it increases with decrease in or decline in CD4 count. And most of the serious opportunistic infections happen if CD4 is less than 200. And that is why you see we give prophylaxis if CD4 count falls below 200. In program, we give CPT below 350 because we also as per the current guidelines, but most of the OI's risk, if you see, that is below 200. And we can suspect OIs based on the CD4. That is why we advocate for like doing baseline CD4, and we try to correlate that level of CD4 with the clinical presentation of the patient so that we can suspect opportunistic infection. If the CD4 is suppose 800 and patient is having some kind of respiratory symptoms, so PCP won't be my first differential diagnosis in that patient. If it is 200, obviously PCP will be my first differential diagnosis. So similarly, all these disseminated fungal, viral, opportunistic infections, and also malignancies, so and even disseminated tuberculosis, it happens if CD4 is below 200. So these are like pooled estimates of opportunistic infections in India. So as we all know that tuberculosis is the most common type, followed by oral candidiasis, diarrhea, and so on. And if we look at the symptoms of or presentation through or presenting signs and symptoms in PLHIV, they are fever, weight loss, cough, dyspnea. These are the common symptoms with which patients present with the opportunistic infections. So we, as a medical officer at ART center, should know when to suspect OI, how to diagnose them, what is the management of OI. If the patient is on ART, then how to again follow up with CD4, when to do CD4, when to start ART in presence of OI, because we say that if we start ART before starting treatment of OI, there is a risk of immune reconstitution syndrome. And all these issues or all these things need to be considered. And when we start with OI treatment, again, the treatment of OI itself can be toxic. So that may interact with ART, and that is why we need to know drug interactions between those treatments. This is a classification of OI based on pathogen. They can be bacterial, viral, fungal, and parasites. So as far as respiratory is concerned, these are the most common OIs you will see in PLHIV, especially if CD4 is low. But other than this is the those infections which affect gastrointestinal tract, like Cryptosporidium, Isospora, Microspora, they are also common if CD4 count is low. And presentation of the OI might vary from asymptomatic presentation, patient being asymptomatic or mild presentation, to disseminated disease symptoms and signs. So it all depends on the, again, level of CD4 most of the times. And the list is pretty long of opportunistic infections, but the common OIs we see and the treatment for common OIs, what we supposed to know, that is not that much, because most of these viral opportunistic infections, they do not need any specific treatment. In fact, even some of the parasitic infection also. So if you start ART in patients and if CD4 goes above 200, then slowly the OIs subside by itself, and then you can continue patients on ART. So the key is to start ART early in patients HIV, and to know when to start prophylaxis and when to suspect a particular OI, to diagnose them early and put them on treatment as soon as you can. So there is these are various opportunistic infections involving respiratory and gastrointestinal systems. So in respiratory, you will see mostly tuberculosis, pneumonias, PCP, and other OIs depending on the, again, geography, you can say. Gastrointestinal systems, candidiasis we used to see pretty often in past. So these days, we are seeing less and less number of patients with candidiasis. But again, they are coming back with evidence of treatment failure for the patients who are already on ART. Then for the viral OIs in our program, it is hard to obviously diagnose or confirm the diagnosis, but clinical suspicion is most important, I guess. And that is why I said if you start ART, you may not need any specific treatment for many of the OIs. So all this list in this presentation, there are like too much of the information, which is for reference and which you can refer to when you want. So we will try to like focus on those important areas which are related to clinical management of the patients. So in terms of diagnosis related challenges, TB, we know that if the bacillary count is low, which is possibacillary or atypical presentation is there in when CD4 counts go very low. So that's the reason if the CD4 is very low, there is no granuloma formation, there is no infiltration on X-rays. So X-ray might look normal. Patient's sputum might be negative because there is no cavity formations. So that becomes a challenge in patients with severe immunodeficiency. And especially extrapulmonary TB, again, collection of samples is one issue. And in children, even getting sputum is not that easy in children. So you may require to do gastric lavage and also to get the sputum sample in those cases. And obviously, the access to radio diagnosis is not that easy in many of the settings where we work in, where CT, MRI may not be available, and even for eye examination, ophthalmoscopy may not be available all the time. So in such situations, to overcome these challenges, there are flexibilities given in the guidelines where you can start ART based on the clinical suspicion but you need to diagnose the patient clinically. It is not just a suspicion. Treating medical officer should be confident or should be able to categorize that patient as a clinically diagnosed TB. Then you can treat that patient with full course of anti-TB treatment. Then candidiasis, usually we do diagnose based on like clinical presentation. But in case of esophageal candidiasis, we need endoscopy. And if it is not available, again, if the patient has odynophagia with pharyngeal involvement of candida, we suspect that it is a esophageal candidiasis. We categorize that patient as stage 4 and we start high dose of fluconazole. Pneumocystis carinii or pneumocystis jirovecii pneumonia, again, we don't do actual gastric lavage, the bronchoalveolar lavage and diagnose or identify the organism as such. We go with the clinical presentation and CD4 cutoffs, and we see saturation of oxygen, and based on that, we start treatment. But again, for that also you need experience and appropriate information about PCP. And that is why it is also a challenge in some of our settings. For cryptococcal meningitis, again, CSF sample collection is not that easy in all ART centers or hospitals where ART centers are located. For medical colleges and all, it may be easy, but for peripheral hospitals, it becomes a problem. And sometimes it is hard to differentiate between new and relapse cases because, again, culture is not available everywhere. And patients who are already on treatment, if they again come with severe or similar situations after symptoms of cryptomeningitis after initiation of ART, it becomes difficult to differentiate. Then toxoplasma, again, radio diagnosis is the most commonly used approach. So if you don't have access to CT, MRI, it is a problem. Chronic diarrhea, to isolate or to diagnose the organism, the lab need to be experienced first of all, and then when you manage patients on outpatient in outpatient care, again, it is hard to get the sputum sample, stool samples and do the diagnosis. CMV retinitis, you need to have access to ophthalmologist most often. Even if you have ophthalmoscope in the RT center, you need pupil dilatation to look at retina, and that becomes a challenge. Now, in terms of treatment-related challenges, one of the most important OI in the CNS and HIV positives is cryptococcal meningitis, and the duration of treatment is pretty long, and also availability of amphotericin B, especially liposomal amphotericin B, which is very expensive, and it is hard to access it in programmatic settings. And even if you have after the initial induction phase, the next phase of treatment, it will be for a pretty long duration. So management of that and follow-up of that is sometimes becomes challenging, and patients may relapse. So that was a general summary of opportunistic infections. It was very brief, I guess, but the one takeaway is, I think, for us, is index of suspicion. Look at the CD4 count in initial 12 months or 1 year of the patients on ART. And of course, if the CD4 is less than 350. And especially if the CD4 is less than 200. And if once ART is started, then close follow-up of that patient need to be done. Again, to ask proper questions to the patients when they show up with symptoms. That is very important to suspect a certain OIs. And then to know where to refer which patient, and to establish those referrals beforehand, and not to look for or search for places to refer when the patient comes. So I think that is very important for ART center. And then starting prophylaxis at proper time, and also following up the patients who are on the OI prophylaxis, and stopping the prophylaxis when it is not needed anymore. And patients who are on OI treatment, following them up closely on the management of OI, and if they are taking the treatment properly or not, and if there are any drug interactions, toxicities. So all these things also need to be seen in addition to monthly prescription of ART to the patients. So CNS opportunistic infections, HIV itself can involve or can affect the central nervous system. It is called as neurotropic virus, and it has predilection to affect the nervous system. So, and the second way through which it can affect central nervous system is through opportunistic infections. So in addition to nervous system, HIV can also affect heart, kidneys, and gastrointestinal tract, and cause diseases of those systems. But all those things happen if the CD4 counts, they go below 200 especially. And many of the patients, the neurological symptoms itself is the first presentation to the outpatient units. So those which are HIV related itself, like I said, when HIV directly affects the central nervous system, it may cause acute aseptic meningitis, chronic meningitis, or HIV-associated neurocognitive disorders, encephalopathies. But OI-related are cryptococcal meningitis, cerebral toxoplasmosis, CMV, progressive multifocal leukoencephalopathy, primary CNS lymphoma, tuberculosis, syphilis. So out of these are, like I mentioned in the beginning, I doubt how many you might see at the level of ART centers, because these are like pretty serious OIs, and patients, when they have them, or with signs and symptoms of all this, they may go to the hospitals first, and they may not come to the ART center. But in the initial phases, the initial symptoms and signs are always visible at ART center if the patient is registered in the ART center or obviously on ART in the ART center, and maybe like failing the ART treatment. So knowing about these infections will help us to suspect these OIs, and when to suspect what OI will be important for us, and then it is possible for us to seek help when we need. So the common symptoms with which, or clinical features with which patients may present, broadly you can categorize into like global syndrome category of OIs and focal deficit category of OIs. So what I mean by that is when you see global cerebral syndrome, the symptoms are more of headache, neck stiffness, or nausea, maybe some cognitive impairments, or maybe some behavioral abnormalities. So those OIs which usually affect meninges or cerebrum itself in terms of having some kind of encephalitis. So those will call global syndrome presentations. But if you have some lesion in the brain itself, like some space occupying lesion, then these usually result in focal neurological deficit, where you will get patients with maybe like homoplegia, some cranial nerve palsies, or hemiplegia, paraplegias, and things like that. So it's good way of dividing the categories of presentations, I guess, because if the patient presents with global cerebral syndrome, you can do the CSF analysis first, and then you can think about the radiological examination. But if the patient comes with focal neurological deficits like homoplegia, hemiplegia, paraplegia, and cranial nerve palsies, you should go for MRI or CT scan first before you put a needle in patient's back, or you do the CSF examination. So symptoms of meningitis are like patient presents with headache, fever, nausea, vomiting, altered consciousness, and it may be because of TB, cryptomeningitis, syphilis, and bacterial meningitis. And focal lesions like tuberculoma, toxoplasma, progressive multifocal leukoencephalopathy, or PML, primary CNS lymphoma, neurocysticercosis, these are very specific to, again, HIV, and you should remember at least these many, so that whenever a patient comes with symptoms of headache, convulsions, focal signs, and if CD4 is less than 200, you can think about these OIs. And these are like treatable OIs with some specific treatments. And most of the encephalitis, viral encephalitis, and at least some of them do not require any specific treatment, but there are some specific treatments required for some specific viral and parasitic infections. Like I said, cryptococcal meningitis is the most commonly discussed and important opportunistic infection, I guess, under this category. So it's a fungal infection basically, and occurs primarily in patients with advanced HIV disease, which means if CD4 is less than 200. It is caused by Cryptococcus neoformans or Cryptococcus gattii, and antigenemia is considered as an independent predictor of cryptococcal meningitis. So there are ways in which patients present, and there are ways in which we diagnose these patients. But if patients are not treated and diagnosed in time, then you may lose the patients. And when the clinical presentation may be subacute in presentation, and most of the patients, they present with headache and fever, and classical symptoms of meningitis like neck stiffness and all may not be present in majority of the patients. But with time, if the patients are late in their disease, they may also be seen. Patients are usually agitated with altered mental status, sometimes present with cranial abnormalities. Sometimes you will see this skin lesions also, that is cutaneous cryptococcosis in these patients. So there are various types of tests which can be done to diagnose cryptococcal infection. One is antigen test. So we can do serum cryptococcal antigen test. Obviously, first of all, let me be clear that cryptococcal antigen test is not available under the program. It may be available within the hospitals where you work, or maybe the other facilities near to you. But in the program itself, it is not available. So generally what happens in the program is when we see these patients, we do lumbar puncture, and when we subject the patients to India examination, and we see cryptococcus. But ideally, these are the options we should be aware of, and whenever there is an opportunity, we should go with these options. So antigen test is very good way of diagnosing in these days. We can do serum cryptococcus antigen, and then also we can do CSF antigen. In short, it is called CRAG. Cryptococcal antigen is called CRAG, and it's a lateral flow assay method. Like I said, we can do microscopy of CSF, India ink and gram staining, and we can also do culture, which is important to again diagnose the relapse cases. India ink is very easy. India ink is nothing but what we use in ink pen. So, and it's very easy. It can be done in the ward itself, and it's but the sensitivity is low. The culture, like I said, CSF analysis, if you do it can show low or normal glucose concentration or low cell count. But the most important thing, when you put the needle while doing the lumbar puncture, the gush of this CSF, or the speed with which CSF comes out, is called as opening pressure of CSF. So usually the normal CSF pressure is less than 20 or 10 to 20 centimeter of water. But if there is a cryptococcal meningitis and patient presents with especially severe headache, then CSF pressure may be more than 25, or it will be very high. Ideally, it should be measured through a manometer, but most of the places, again, in our settings, it may not be available. So if you are experienced in doing lumbar puncture, you will be surely able to differentiate a normal flow with the high pressure or high opening pressure. But that is not the ideal way of measuring it. And one more thing about, again, CSF, the cryptococcal meningitis, which is important, I think, conceptually to know that the rise in pressure is because of blockage of the CSF flow, and it is not because of inflamed subarachnoid space. So if you remember, like CSF flow, there are like lateral ventricles, third ventricle, fourth ventricle, and there are cisterns. So CSF, actually, it is produced in the lateral ventricles. So, and then it flows through all these ventricles, and then subarachnoid space and central canal of the spinal cord. And when, due to the fungal load or cryptococcal antigen load, where it gets reabsorbed through arachnoid villi and granulations in the subarachnoid space in the nervous system. So if those arachnoid villi and granulations are blocked, the CSF reabsorption is affected. And that is the reason the pressure of CSF within the nervous system, within these ventricles and everywhere, it goes on increasing. And that results in headache. Usually in the treatment of meningitis, we give mannitol or steroids to reduce the inflammation and to increase the reabsorption of the CSF. But that doesn't happen in cryptococcal meningitis, and that is why, unless you treat the crypto or you take out the CSF, the symptomatically patients will never improve. And that's the reason once you diagnose the cryptococcal meningitis and start patients on treatment, it is also important to take out the CSF in higher quantities by repeated lumbar puncture, which is called a therapeutic lumbar puncture or therapeutic tapping. You can remove up to the level of 30 ml of CSF in daily from the patient, if obviously the patient is diagnosed as confirmed as having cryptococcal meningitis. Because why I'm stressing upon this point is, if you do this in other patients, it is very risky. It may cause coning, and which is very bad situation, I guess. So you should not be doing this in other types of meningitis, and where we use mannitol and steroids for increasing intracranial tensions. But in cryptococcal meningitis, because the issue is poor reabsorption of CD4 due to blocked arachnoid villi granulations, it's safe to remove CD4, remove CSF in these patients to reduce the opening pressure of CD4 of CSF. Of course, this is in addition to the treatment which we give to the patient in terms of high dose antifungals. Okay, so again, getting back to the diagnosis first, we can do, if the crag is available, do the serum crag first, and if serum crag is positive, you do lumbar puncture and do CSF crag. And if both are positive, obviously the patient is having cryptomeningitis. If the serum crag is positive, and if you're not able to do, suppose, CSF crag because of any reason, but if the patient is symptomatic, you still might conclude that patient is having cryptomeningitis, and you end up treating the patient. And if crag is not available, and if the patient is symptomatic, and if lumbar puncture is showing India Inc. examination positive for cryptococcus, then and if you are not able to treat or do the treatment in your center, you should refer the patient to the higher centers. So ask for when the patient shows symptoms of cryptococcal meningitis, we should ask the patient about the onset of symptoms. And if there are any specific, non-specific symptoms, we shouldn't miss them. If the patient has been already started on ART, then think about immune reconstitution syndrome. And the skin lesions can be very important sometimes. They look very similar to molluscum contagiosum lesions, but that can be one sign through which you can suspect. Then serum crag is recommended if CD4 is less than 200 with or without symptoms suggestive of cryptococcal meningitis. So in patients with severe headache and cryptococcal meningitis, while on treatment, we can do therapeutic tapping in those patients. And all patients who are positive for serum crag, we should subject them to lumbar puncture and CSF examination. And as I said, India Inc. is, though, very simple and easy. The sensitivity is a bit low, but it is specific. If you see, it is cryptococcal meningitis. That's why it is called as a screening test, screening of crag, followed by preemptive antifungal therapy among crag positive patients. So if the patient CD4 is less than 200 and serum crag is positive, and if CSF crag is negative and there are no symptoms, you should treat these patients with preemptive treatment antifungal therapy, which means it is kind of like a treatment before you get disseminated disease as such. So crag is screening is not recommended in children. Of course, this is all when you have crag availability in your setup. Otherwise, we obviously don't do this. It is low in children, so less than 10 years, we don't usually do it. So this is how you actually interpret the results of CRAG. If the CD4 is less than 200, you do serum CRAG. If it is positive in serum, then we do lumbar puncture and do CSF CRAG. If both are positive, it is cryptomeningitis. If serum CRAG is positive and CSF CRAG is either negative or not feasible to do, if patient is asymptomatic, then do give preemptive treatment. If patient is symptomatic, then treat for cryptococcal meningitis. If serum CRAG is negative, if patient is symptomatic, then evaluate other causes. If asymptomatic, then standard package of care. If not feasible to do CRAG, which is in most of our settings, if the patient is symptomatic and showing symptoms of meningitis, or maybe like presenting with this typical symptoms of headache, sometimes projectile vomiting, sometimes neck stiffness, and maybe confusion, and all these symptoms of meningitis, you may consider evaluation for TB, cryptococcal meningitis, bacterial meningitis, and may consider presumptive treatment of cryptomeningitis and bacterial meningitis based on symptoms or report. So if patient is asymptomatic, then fluconazole primary prophylaxis is recommended if CD4 count is less than 100. So this is the, I guess, the new recommendation. So if patient is CD4 less than 100, you can still give primary prophylaxis with fluconazole to prevent the development of cryptococcal meningitis in future. Okay, so preemptive treatment of PLHI with asymptomatic cryptococcal infection. So offer this treatment if serum CRAG is positive, and ideally everyone who is tested as positive with serum CRAG should go for the CSF examination of antigen, and then you need to start patients on treatment if that is also positive. Otherwise, just treat patients with serum with preemptive treatment. How preemptive treatment is given: fluconazole 800 milligram per day, or as an induction phase, and then fluconazole 800 milligram for 8 weeks. So total 10 weeks of fluconazole in 800 milligram, and then maintenance dose of that is 200 milligram of fluconazole, unless there is an indication of immune reconstitution. That means if CD4 goes above 200. So this is one situation, that is cryptococcal meningitis is one situation where we actually delay ART initiation as against other OI treatment, where we actually start ART early in OI treatment phase. So in fact, cryptococcal meningitis and bacterial meningitis or tuberculosis meningitis, these are two situations. TB meningitis and cryptomeningitis are two situations where it is recommended that ART initiation should be delayed for 4 to 6 weeks, so that we achieve proper separation of bacillary load and fungal load, and there is a lower risk of immune reconstitution syndrome. Otherwise, if you start ART early in these patients, patient may die because of iris or maybe like resurgence of opportunistic infections. This is very important point to remember in case of cryptomeningitis. So primary prophylaxis is not recommended generally. Because we don't see cryptococcal disease that much. But if CRAG is not available, which is the case in most of the ART centers as of now, you can give primary prophylaxis if the CD4 is less than 100, and it is given with fluconazole in the dose of 100 milligram, and continue it until you receive the evidence of immune reconstitution, either with CD4 above 200 or with suppressed viral load. So treatment of cryptococcal meningitis, we have this induction phase where we give amphotericin B. Wherever it is available, it should be given. The liposomal amphotericin B should be given, but as I said, it is more expensive than the regular amphotericin B deoxycholate. So it is given IV for like 1 week, and then along with flucytosine, and then it is followed by fluconazole 1200 milligram per day for next 1 week. That is 1 week of amphotericin B liposomal or deoxycholate and flucytosine, which is again, it is difficult to arrange for. And then next week you can give fluconazole. But if that is not available, you can still give like two weeks of high dose of fluconazole, like 1200 milligram, along with flucytosine. And if that is also not available, then you give 2 weeks of amphotericin B and fluconazole, like 1 week each. That should be enough. But there are like recent WHO guidelines according to which if you have availability of liposomal amphotericin B, you can just give like 1 dose. And this guideline was released in last year, 2022. It is not yet included in the national guidelines of NACO, but that might get added in the NACO guideline when the next revision happens. But as of now, this is the current guideline. So the next is consolidation phase. After 2 weeks, the fluconazole like 400 milligram is given for 8 weeks, and then maintenance phase where fluconazole 200 milligram is given up until you receive the immune reconstitution. And based on that, you decide discontinuation. And usually it is given at least for 1 year of treatment. So this is the time when patients actually are with you and not with the hospital. And that is why it is important for us to ensure that patient continues this maintenance phase and the secondary prophylaxis. So these are the special recommendations for raised intracranial pressure, which we just discussed, that we need to do therapeutic lumbar puncture in most of the patients where the opening pressure is high. And for administration of amphotericin B, few things need to be again considered. Like I said, cost, it is expensive, liposomal amphotericin B. And then the patients may need magnesium along with the regular amphotericin to because it may cause increased excretion of magnesium through renal route. And also in addition to that, it may cause hypokalemia, and that is why supplementation may be required in those patients who are on amphotericin B. Serum creatinine need to be done in those patients who are on fluconazole, amphotericin B, that is on like baseline after 3 days, after 7 days, because it may affect renal functions. And full blood count can be done at the baseline in 7 days. And for febrile reactions, you can give paracetamol, and sometimes steroid may be indicated in those situations. The relapse is not uncommon, especially if you give insufficient treatment. A relapse is common, and these can be fatal. And also, immune reconstitution can happen after initiation of ART. One of the best ways to differentiate relapse from because if you treat, then there is a destruction of these cryptococcus in the CSF. But if you do cryptococcal antigen test, it may continue to be positive for a long time. That doesn't mean that patient has active cryptococcal disease. So if you want to differentiate relapse from the previous infection, cryptococcal antigen test may not help you. So in that case, doing cryptococcal cultures are important. If the organism grows on culture, it means the infection is still there, and you'll have to treat the patient. But it may not be available in many of the settings. That is why clinical suspicion is very important. And the most basic and crucial thing is to make patients, or to support patients in completing the complete treatment of cryptococcal meningitis with maintenance phase, and also the secondary prophylaxis with 200 milligram. So you know that immune reconstitution syndrome is common, and that is why we delay ART initiation in these patients. The other etiologies of relapse They can be persistently elevated intracranial pressure because of, like I said, blockage of arachnoid granulations by fungus. And there can be co-infections with tuberculosis and bacterial meningitis. So that also need to be kept in mind. So if the patient has cryptomeningitis, the patient may have co-infection with TB, patient may have concomitant bacterial meningitis, and some patients require treatment for both. So that also need to be suspected while treating these patients. So this is again a repetition of the flow which I tried to explain in the beginning. The patient, practically in our situation where you do not have access to CRAG, when patients comes with throbbing headache and maybe projectile vomiting and maybe other signs and symptoms of meningitis like confusion and all that, if the CD4 is less than 200, hospitalize the patients and do lumbar puncture, do India Inc. That is the usual way of doing it, and start treatment. But if you have access to CRAG, then doing serum CRAG is very helpful. If it is negative, you can rule out crypto at that point. You can think about other causes of meningitis. But if it is positive, do all the efforts possible to get the CSF CRAG done. And if the CSF CRAG is also positive, then obviously it is a cryptomeningitis and it has to be treated. And if it is negative, and if serum CRAG is positive, then it is, you need to treat this patient with preemptive treatment, that is 400 milligram of fluconazole. So that's about cryptomeningitis in a nutshell. I know I'm going a bit slow for this presentation, but I think that was one important, that is one important disease which I wanted to cover. The other diseases, we can go a bit faster from here. Toxoplasma, again, as I said, with early ERT, we are seeing less and less. It is caused by a protozoan, which is called Toxoplasma gondii, and which is in cat feces. And that is why if PLHIV with severe immune suppression, they should be away from domestic animals, especially cats. And the food should be like cooked properly before eating. That helps a lot, because this is the way it gets inside the body and cause these serious infection. So if the patient CD4 count is very low, then these should be suspected. Usually the presentation is patient has the space occupying lesion because of the toxoplasma, and they can be single or multiple space occupying lesions, and patient may present with focal neurological deficits. And also the seizures are very common, like convulsions are common, patient may end up in coma. You can see these space occupying lesions on the CT scan images. You can do PCR. It is highly specific, but sensitivity is very low. Antibody tests, usually they don't help for diagnosis. Again, clinical suspicion and radiological support is usual way of making a diagnosis. It's hard to differentiate unless you have access to doing brain biopsy and seeing under the microscope. It is hard to differentiate this with TB, tuberculoma, or other type of space occupying lesions. Usually tuberculomas are single, but that is again not a rule. Usually toxoplasma lesions are multiple, but again that is not a rule. Other causes of space occupying lesions like primary CNS lymphomas, neurocysticercosis, all those also need to be kept in mind when you treat the patients for toxoplasma. So whenever patient presents with headache and confusion, ask if they had any convulsions in past, if there is any motor weakness. If they have undergone already MRI, we can look at the images. If not, then do all possible efforts to get the MRI or CT scan done. And do this first before you put a needle in the subarachnoid space. So lumbar puncture, if CT scan is normal, then you can go for lumbar puncture. Like I said, other differential diagnosis can be tuberculoma, CNS, primary CNS lymphoma. It can be progressive multifocal leukoencephalopathy or PML. And it can be, in fact, the other neurological diseases like Chagas disease or CNS tertiary syphilis and all that, or neurosyphilis. But again, the presentation will give you a clue. Based on that, you need to investigate the patients to make a proper diagnosis. Treatment is total duration is 6 weeks for any acute infection. You can start with pyrimethamine 200 milligram, a single dose, and then followed by 50 to 75 milligram of pyrimethamine based on patient's weight. And then along with that, you can give sulfadiazine. Sulfadiazine is hard to find practically in most of the places. So that is why we can also give cotrimoxazole or sulfamethoxazole in high doses in these patients. And again, these patients will be started on treatment, and then there will be a maintenance therapy, and that is where patients may come to you with reduced doses. Like we start with 50 milligram, and then we can reduce to 25 milligram of pyrimethamine, and then sulfadiazine dose will go up. And then the alternatives are clindamycin and cotrimoxazole. So all these treatment regimens are important to know, because if the patients are on treatment, they will be following up at the RT center every month. So we can again check if it is going properly or not. So there is no, there is a specific prophylaxis for toxoplasma. It is nothing but cotrimoxazole. So the cotrimoxazole we give to the patients if CD4 less than 350, it prevents not only PCP, but it prevents toxoplasma, some of the pneumonias, and also some of the diarrheal diseases. So it is very important to give cotrimoxazole prophylaxis in patients if CD4 count is less than 350, and especially if the CD4 count is 200. And if patient has allergy to sulfur, then you can give dapsone 100 milligram in those patients. Cytomegalovirus disease, the most common or the most important disease which we are actually worried about because of this virus is CMV retinitis, because it may cause permanent blindness in patients. But there are other presentations of CMV. It can cause colitis, esophagitis, and other presentations. But it especially happens if CD4 count is less than 200. It is called as end organ disease when it affects retina. Patient may present with diplopia or double visions or floaters or scotomas. And if in such such patients, if they present with this, if you can do ophthalmoscopy within the RT center, you can do it if you are experienced, or you can send the patient to ophthalmologist for diagnosis and further treatment. And if the patient is diagnosed with CMV retinitis, the treatment has to be started immediately. And if you look at the treatment of these patients, then these days it has been simplified with the availability of valganciclovir. So with valganciclovir, in the dose of 900 milligram, you can give like 12 hourly for first 2 to 3 weeks, and then 900 milligram OD can be given as a maintenance dose. So injection ganciclovir is an alternative, but if you are giving injection ganciclovir, then switch should be done to oral ganciclovir when there is a clinical improvement. And it need to be continued based on the, again, patient's if patient's immunity improves, then it can be again discontinued. So this chronic maintenance therapy is required, maybe 3 to 6 months in patients if CD4 count is very low. You may see some like peripheral lesions also, and in that also the treatment is almost similar. In some cases, you need steroids as well, but we don't see it very commonly. You may see if the patient has odynophagia, which is not getting cured with fluconazole, and if you're suspecting, suppose, esophageal disease, then in those patients, if oral candidiasis or oroesophageal candidiasis, the patient is not getting better, then you can suspect CMV esophagitis also, and in those patients may require valganciclovir. So again, diagnosis in our settings is not that straightforward, but clinically you can keep that in your mind. Meningitis, again, there are many causes. It can be TB, bacterial, viral, or fungal, or there are many other causes. So if it is bacterial meningitis, typically the patients, it can be because of Streptococcus pneumoniae, H. influenzae, or Neisseria. Patient presents with headache, and typical symptoms. You can give third generation cephalosporins like ceftriaxone, and then you can follow the patients. Patient will be hospitalized in these situations, and patient may require some higher antibiotics like vancomycin for gram positive, and patient may need IV treatment for 10 to 14 days, and then oral treatment can be given in those patients. TB meningitis treatment is similar. Only thing is that the continuation phase can be prolonged in such patients. Sometimes it is challenging to differentiate between bacterial meningitis and other type of meningitis, but with the help of all these protein, sugar levels, and wherever it is possible, if there is any specific test can be done, you can also differentiate between different types of meningitis. But the problem comes if there is multiple infections at the same time, then you need to clinically decide when to start which treatment in what patient. PML is again progressive degenerative disorder, where you will progressive disorder is caused by JC virus. It causes demyelination, and it causes leukoencephalopathies. That is, gray matter is converted into white, and that is where you can see that it starts initially, and patient may present with general confusion and those types of presentation, but it may continue to grow if ART is not started. There is no specific treatment for this ART. If you start ART, you can halt the progress, but it is difficult to reverse the damage which has already happened. Now, the one feature which is different from the space occupying lesion is there is no deviation of the central line. If you look at the center line here, so there is no pressure effect. Usually, if you have any space occupying to pressure effect, there is a push of the center line to the opposite side. But in JC virus infection or PML, you will just see the whitening in the CT film. The other HIV-associated neurocognitive disorders, again, these can be minor, or these can cause dementias. So all these infections, all these diseases, it is difficult to confirm the diagnosis. So usually the diagnosis is diagnosis of exclusion. If you have excluded the other infective causes, you can then make a diagnosis of these based on their clinical presentation. And again, as I said, there is no specific treatment other than ART in these patients. So early initiation of ART and regular ART may halt the progress or may reverse in some cases, but not in all cases. And again, primary CNS lymphoma is the most common space occupying lesion. If that is, and especially it can happen if the CD4 is less than 100. The cause is Epstein-Barr virus. Again, starting with the usual chemotherapy is not of use, but ART is really helpful. And HIV-associated nephropathies, or neuropathies, peripheral neuropathies can also happen because of HIV. Again, no specific treatment. But the other causes of neuropathies need to be addressed, like if the patient is on INH, and if there is any pyridoxine deficiency, if the patient is on taking alcohol, and if the patient is diabetic and that is causing neuropathies. So those need to be addressed in addition to ART. And lastly, about neurosyphilis, if the patient has, this is a tertiary syphilis, and the risk of neurosyphilis is high if the patient is having obviously untreated primary syphilis and is not taking treatment properly for initial presentation of the syphilis. So the treatment is with benzathine penicillin, and you can do CSF VDRL for and to see the organism. And treatment with benzathine penicillin can continue for 10 to 14 days. And patient need to be again re-examined every 6 months until the white blood cell count goes to normal. And retreatment should be considered if CSF white blood count does not decline after 6 months, and it's not normalized after 2 years. So yeah, so that's a long presentation, I guess. It has more than 100 slides. That's why towards the end I decided to go fast. But as I said, mostly the information in this presentation is to build a knowledge, and hardly you will be able to manage these patients in the outpatient or ART OPD. But as an ART medical officer, you should know of all these serious opportunistic infections, and we should be ready and know our linkage pattern or referral mechanisms to make it easy for the patients whenever they come to you, and participate in the management. If possible, go to the wards and see these patients so that you'll understand what happens and how the patients are managed, and what needs to be done when they come back to the ART center. Non-CNS, there is one question I can see in the chat, non-CNS cryptococcal meningite management. It is not very different from CNS. In fact, it depends on, again, severity of the presentation. If it is not severe, you can just give, can treat with fluconazole. But of course, like I said, the recent change in WHO treatment guidelines, like single dose of liposomal amphotericin along with flucytosine and high dose of fluconazole, it makes our life very easy to when we want to manage. Do you feel vitreitis of the eye with VDRL serum positive CSF, total count 4 cells, protein normal? Do you feel it is neurosyphilis? Because if VDRL serum, VDRL is serum positive. So again, this is CSF VDRL, I think need to be done. And if that is positive, it is confirmed. Otherwise, it is hard to confirm. In if CSF VDRL is negative, then it is obviously hard to confirm. But if patient is not improving, generally you can still treat with, I think, benzathine penicillin with suspicion of tertiary syphilis, especially if the CD4 count is very low. Yeah. But again, there is no harm in having consultation with a neurologist, and based on consultative decision, you can proceed. It's hard to comment on that. Thanks, Dr. Swami, for those questions. And thank you, everyone, for your participation. And I hope to see you again in the next session on 28th of March.
Thank you, sir, for this wonderful session. Participants are also requested, if you please unmute your mics and ask the question if you have any question. I think there is no question, sir. I will just quickly run the feedback poll.
Okay, thank you, Kiran. Thank you, everyone.
Participants are requested, please fill that feedback poll. Thank you all for attending this session. Sir, can we conclude this session now?
Yes, thank you, Kiran. Thank you, everyone.
Thanks.